Hello everyone, my name is Carl Nnabuife, and this is my presentation on the implementation of a discharge checklist. So the committee members for my project chair is Dr. Tanya Crystal, the second reader is Dr. Jennifer Brutworth, and then the community member is Chelsea Murrell. She's the unit manager on the unit that I did my project in. So the background of this project, discharge is a very important process in healthcare and nursing practice, as it provides a transition for patients going from one healthcare facility to their next plan of care, whether they're going to another healthcare facility or whether they're going home. So it's important that discharge is being done correctly so we can promote these positive patient outcomes and decrease the risk of complications and or readmissions. Even though we want these discharges to be done correctly, they often get done incorrectly. And that's what was discovered on this designated unit. So they found that they had low patient satisfaction scores in discharge education. So before I get into how low these patient satisfaction scores were, I'm going to go ahead and fix your attention onto the diagram on the right upper hand corner. So this diagram is a legend, and it represents how we quantify and organize our discharge satisfaction scores. So we organize it based on color and based on categories, based on the ranges of the patient satisfaction scores. So the first category is below threshold, and that is in red. And these scores range from 74% to below. And the reason why that the below threshold is highlighted is because that's where the scores were. They're really low, and it was ranging from 50 to 60%. So these scores were really low. So this was one of the reasons why this project was being implemented in the first place, so we can get those scores higher. Then the next category is threshold, which is in yellow, and these scores range from 74% to about 80%. And then target, which is represented in green, the scores range from 81% to 85%. And then we go to superior, which is represented in blue, range from 86% to 100%. And the reason why target and superior are bolded is because that's the goal. We want our scores to either be on target or superior. But even with these incorrect discharges, there's statistics backing this up. So it's found that 30% of these improper discharges were due to improper communication, medical errors, and adverse events. And as a result of these improper discharges, it's cost Medicare about $17 billion annually. So not only from a patient standpoint, but also from a financial standpoint of the importance of why discharge needs to be done correctly. So it's found in the literature that the discharge checklist was effective in improving the discharge process and patient outcomes. And this is another reason why this project was implemented. So the aims for this project is to implement the discharge checklist on the unit. We want to improve the discharge process and patient satisfaction scores in discharge education. We want to foster good communication and proper and correct documentation. And then we want to decrease adverse events, readmissions, and medical errors. So the literature review, three themes were found. The first theme was improper discharges due to the incomplete documentation. The second theme is the improper discharges due to the lack of communication. And then the third theme was improper discharges due to an increase of readmissions. And these three themes, the causes of these themes were due to the fast-paced nature of healthcare, the increased responsibility of staff members, patient noncompliance, polypharmacy, and medical errors. So let's get into the theoretical framework. So the theory that was utilized for this project was a translational theory. And this theory discusses the interconnections and complex organization structures that are important when we want to translate evidence into practice. And in the specific model under that theory that was utilized for this project is the Ottawa model of research use. So this model was created in 1998, and this model focuses on using existing evidence that's already out there and is already implemented in practice, and you use that to apply it to current practice and impacting patients, impacting healthcare providers, and impacting the healthcare system as a whole. And the reason why that this model was utilized was because there's already been existing evidence, and I discussed it earlier how these articles were saying that the discharge checklist was very effective in improving the discharge process and patient outcomes. So it's been tested. There's many studies on it, and they found that this discharge checklist was successful across multiple studies, across multiple facilities. So that's why I felt that this theory, this model, like kind of fitted with my project, and it made sense with it. So the impact that this theory has brought to my project, so it increased the knowledge, in the sense it increased the knowledge of the model and of the translational theory. With the model, it increases the knowledge of me understanding the three elements of the Ottawa model of research use. So the first model is to assess the intervention, consider the evidence associated with it, consider the factors. Then the second element is to implement this intervention. And then the third element is to monitor and evaluate outcomes and see whether these outcomes and whether the evidence that was found can be translated into practice. So as a result of understanding and increasing this knowledge, it has brought clarity and understanding to my project by making these connections and making the relationships, and also it has helped to utilize critical thinking skills by knowing and understanding how these factors can contribute to bringing this evidence into my practice in the near future. So the methods and design that was utilized for this project. So the study design was a quantitative, non-experimental pre-test, post-test study design. So the reason why this design was utilized, quantitative is just based on the data that we're getting, which is the patient satisfaction scores and percentages. The non-experimental is because we didn't use any human subjects, and we'll discuss about that in the next slide. And the reason why we use the pre-test, post-test study design, because we're implementing a new intervention, which is a discharge checklist, which we haven't done before. So this design made the most sense. So the study setting is the medical surgical unit and a magnet acute care hospital. So the first step of this project, we have to get this project to be displayed across many forums. We have to get people to know about this project. So this project was informed through staff meetings, emails that they were getting before implementation, and emails that they were getting monthly while the project was being implemented, and then daily shift huddles. And then once after that, then the 1 week study trial period was implemented. And the reason why this period was implemented was so that way everyone can get accustomed to the discharge checklist and to the project, and so it can be better implemented across the unit. Next, then the project was implemented for 3 months, and for those 3 months, the nurses were using the discharge checklist from patient admission to patient discharge. And then while these 3 months were going on, data was being collected through the patients completing the PRES gaining survey. And we focused on 2 questions based on discharge education. So the first question was whether the patient was educated in conversation with the staff. And then the second question was whether the patient was being educated in writing about the health and about their symptoms. And then based on these responses, they were recorded and tallied, and the scores were calculated based on the yes responses over the total amount of responses, and that's for pre and post intervention. So like I was talking about previously about the sample, there is no human subjects. Our sample is the aggregated data from the PRES gaining survey from the responses we got from the patients within that 3-month time period. And then as a result of not having any human subjects, we were exempt from review from the institutional review board from Maryville and from the facility. So this is just a diagram showing how the sample is represented by gender, and you can see with pre and post intervention that it's mainly female, 54% for the pre intervention and 56% for the post intervention. And then we have figure 2 where the sample is organized by race, and you can see with the diagram for pre and post that the overwhelming majority of the race is Caucasian, and then African American, and then Asian, decline, and then Hispanics and unknown. So the data analysis, we utilize SPSS, and that's the statistical software that was utilized for the data analysis. But the test that was utilized for this project, we used the upper tail z-test, difference of 2 proportions. And the reason why this test was utilized was, first, these samples, pre and post, these groups are independent from one another. The second reason was the sample size was greater than 30. The third reason was the samples had a normal distribution. And then lastly, the sample utilized ordinal data, which is the percentages of the patient satisfaction scores. So here are the results for table 1. On the first column where it says help needed, that represents the question about whether the patients were educated with conversation with the staff members. And you can see the z-test statistic was 0.4232, and then with the p-value of 0.6639. And with the second column, with the symptoms or the health problems, that's the discharge question related to where the patients got their information in writing. So the z-test statistic was 0.9708 with the p-value of 0.8342. So the limitations associated with this study, the main limitation is nursing compliance. So some of the nurses felt like the intervention was too complex, and or some of them didn't want to implement the intervention based on their own reasoning. And then lastly, the last limitation was the short study period. So for the discussion, so there is no statistical significance between the discharge checklist and the patient satisfaction scores and discharge education. So this means that the discharge checklist did not improve patient satisfaction scores, even though we're expecting, based on previous evidence, that the discharge checklist was going to improve the discharge process, improve patient satisfaction scores, and improve patient outcomes. So the implications for practice, as a result of the statistical insignificance, there's been no changes to practice in healthcare. Even though this is the case, this project does highlight the importance of discharge as a process in healthcare discharge education, and patient satisfaction in health and in nursing practice. So for the conclusion, there is no statistical significance associated with the discharge checklist and patient satisfaction scores in discharge education. Even though this is the case, this project does a good job in addressing these low patient satisfaction scores in discharge education. Further research is needed to find the root cause of these low patient satisfaction scores in discharge education, and further research is also needed to find other solutions to help streamline the process, since the limitation was some of the nurses felt like the intervention was too complex for them. So recommendations for future study is recommended to increase the study period. Upon reading the articles, it was found that they utilize a study period of 6 months. So it was recommended to increase the study period to 6 months when the study is done in the future. Also, another recommendation is to obtain more nursing feedback. So we do have in the unit admission and discharge nurses. So it will be a good idea to get more feedback and recommendations from them along with the staff nurses that are actually doing the discharge education on the job. Just to further support the data and to further increase nursing compliance. And it's recommended to increase the sample size just so we can get more accuracy and more quality in our data. So for the nursing impact, this project and this program has helped me to increase my nursing knowledge in the sense that it's helped me to understand what advanced nursing practice means and how that's going to impact me in my future career and impact me as a student. As a result of increasing my nursing knowledge, it has helped me to become more self-confident within myself. I feel like if I can go through this strenuous, hard program, I feel like I can accomplish anything else in the world. This program has been very hard, very stressful, very strenuous, strained me physically, emotionally, and mentally. And if I can get out there and get a degree from it, I feel like I can accomplish all the other dreams that I have, that I want to do in my life. And then lastly, most importantly, that the learning never stops. So in this program, I've learned a lot doing with this project, but after learning all this, I realized I still have a lot more learning to do. I still have a lot more to learn about what advanced nursing practice is and how that's going to affect me in my career when I become an advanced practice nurse. So I'm going to go ahead and open the floor for questions that y'all have. Okay, so we're going to go ahead and go to the references. So this is the first page of the references that were used for this presentation. And then here's the second page. So I want to personally thank everyone for tuning in to this presentation. I want to thank everyone who helped to contribute their input or their recommendations and their feedback for this presentation. I really appreciate it. Thank you very much and have a great day.